Hello everyone, I'm Dr. Dera. I'm obstetrician and gynecologist. Today we'll discuss about history taking in obstetrics. The process of taking history and performing physical examination in obstetrics and gynecologic patient present a unique challenge because of the sensitive nature of the issue to be discussed and the cultural impact on the women to discuss on the reproductive issues. So when we evaluate the woman, we need to be empathic, we need to establish trust, create a comfortable, private and relaxing environment, provide a user-friendly service. This will encourage the woman to discuss matters more openly with you, which allows you to take a detailed obstetrics history, which is very important for every obstetric patient. So, the components of obstetrics history can be summarized under the following subheadings. Like we can start from identification, chief complaint, history of present pregnancy, past obstetrics history, past gynecologic history, past medical and surgical, personal, social, family history, and finally the functional inquiries. So, under identification, we are expected to mention the name, age, marital status, occupation, religion, detailed contact address of the woman, and the mode of arrival are very important. The chief complaint, which is also termed as presenting complaint, is the main reason for a woman to visit the health facilities, and it is advisable to use open-ended question to elicit the chief complaint. There are several reasons for a pregnant woman to visit the health facilities. Some of them are she may came for routine ANC follow-up, for the complaint of vaginal bleeding, minor complaint of pregnancy, decreased fetal movement, and so on. History of present pregnancy is the most important part of the obstetrics history. It includes the review of the past reproductive performance, accurate dating of the present pregnancy, description of antenatal care follow-up in detail, fetal movement, as a fetal well-being should be mentioned, the detailed nutritional history, finally the pertinent positive and negative statement should be mentioned. So, under the past reproductive performance, we need to mention the gravidity and the parity. When we say gravidity, it is the total pregnancy experience, irrespective of the outcome. That can be live birth, stillbirth, abortion, ectopic pregnancy, molar pregnancy, including the current pregnancy should be included. Under the parity is the pregnancy that extends beyond the age of viability. So the age of viability varies in different countries, but in our setup, we said the pregnancy is viable if it extends beyond 28 weeks of gestation or the fetal birth weight greater than 1,000 grams. In many developed countries, they use 20 weeks as a cut point for fetal viability or the fetal birth weight more than 500 grams, they considered as viable. So, accurate dating of the present pregnancy is also a very important component. It is based on the first day of LNMP if the woman remember. But the problem is 25 to 40% of the women may not remember their first date of last normal menstrual period. If a woman knows the first date, so we can calculate EDD and gestational age in completed weeks. Before calculating EDD expected date of delivery and the gestational age, it is very important to ascertain the reliability of LNMP. So how can we ascertain the reliability? First, we need to ask the details of the menstrual history. So to take it as a reliable, it should be regular, the amount shouldn't be changed. And if the woman is taking hormonal contraceptives like OCP, after discontinuation, if she sees 3 regular menses, we consider it that it is reliable. And if she was taking injectable contraceptives, so 6 regular menses, if she sees 6 regular menses after discontinuation, we said the menses is regular. If the woman is lactating, 3 regular menses is expected to take the date as a reliable. So once the reliability of LNMP is ascertained, we can calculate expected date of delivery and the gestational age in completed weeks. If we use the Gregorian calendar, the Nagel's rule should be used. that is EDD equals to LNMP minus 3 months plus 7 days. If we use Ethiopian calendar, we can calculate the EDD like LNMP plus 9 months plus 10 days if the EDD doesn't jump to the next years. And if EDD jump to the next years and the POGME is supposed to be 5, we use LNMP plus 9 months plus 5 days. And if EDD jump to the next years and the POGME is said to be 6 days, we can use LNMP plus 9 months plus 4 days. So gestational age can be calculated, the date of visit minus LNMP, we can get the gestational age in date, which can be converted to in completed weeks. So when we calculate the gestational age from LNMP, our assumption is the woman had regular menstrual cycles with ovulation occurring in 14th day. So when we say it is, the ovarian phase of menstrual cycle is classified into two, as we know. That is the follicular phase, which is variable, causing the variability of menstrual cycle. And the luteal phase is relatively constant, which is most of the time 14 days. So if the woman's menses is every 28 days, the luteal is 14, the follicular is 14. But this may not always be true. If the woman's menses is regular and if it comes every 35 days, we calculate LNMP and then we take the luteal phase, it is 14, and the follicular phase is 21. So, but we calculate with the assumptions of the follicular phase 14. So we were wrongly subtracting 7 days from this woman's gestational age. So we were supposed to add 7 days to get the accurate gestational age. If her menses comes regularly every 21 days, as we said, the luteal phase is 14 and the follicular phase is 7 days. So we were adding wrongly extra 7 days to calculate the gestational age. So to get the exact one, we were supposed to subtract 7 days from the calculated gestational age to get the exact one. So this is very important. This adjustment is very important to reduce the risk of pseudo postterm and pseudo preterm pregnancy. And based on the calculated gestational age, we can classify the pregnancy as preterm if it is gestational age is below 37 weeks, term pregnancy is 37 to 42 completed weeks, and the term pregnancy can also be classified as early term if gestational age is 37 to 38 plus 6, and full term 39 to 40 plus 6, and late term 41 to 41 plus 6, and the post term if the pregnancy extends beyond 42 completed weeks. So if the first date of last normal menstrual period is unknown, there is no need to describe the details of menstrual history at the beginning of our history, because, and also history of contraceptive is, we don't need that one because there is nothing that we ascertain reliability since the LNMP is unknown. So the most important part of history here is just checking the milestones. So we need to elicit the following histories. The milestones are very important to know the gestational age of the pregnancies. These milestones include early ultrasound. We said early ultrasound. If a woman had an ultrasound before 24 weeks of gestation, we can use to calculate gestational age. Most textbook and also says ultrasound before 20 weeks should be considered as an early ultrasound. But the WHO said ultrasound taken before 24 weeks can be used to calculate gestational age. If ultrasound, the first trimester ultrasound had a margin of error of 5 to 7 days, and the second trimester ultrasound 10 to 14 days, and the third trimester we don't use it because the margin of error is plus or minus 3 weeks. If the woman had the first date of urine HCG test, if she remembered that, we can use to estimate the gestational age from the positive urine HCG. If 36 weeks passed, we say this pregnancy is grossly term. The first date of fetal heartbeat positivity by Doppler ultrasound can also be used, because the Doppler is supposed to be positive at 10 weeks. If 30 weeks passed from the positive Doppler, we said the pregnancy is term. Date of quickening. Quickening is the first perceptions of fetal movement by the mother, and is supposed to occur in at 16 to 18 weeks of gestation in multiparous women, and 18 to 20 weeks of gestation in primiparous women. So we can estimate based on this. And the fundal height calculated at 20 weeks can also be used to estimate gestational age. The details of antenatal care follow-up should also be documented here. If the woman has no antenatal care follow-up on the previous pregnancy as well, and the late start antenatal care follow-up, we need to mention the reason. And the details at each visit should be mentioned. What was done? History, physical examination, blood test, urine test. If the woman remembers the result in the nose, we can mention. And also any intervention given during each visit should be elaborated in detail. Any complaint of the woman should be asked and should be described in detail. The fetal movement should be asked. The details of the nutritional history is an integral component of history of present pregnancy. And the pertinent positive and the negative statements are very important to identify the possible differential diagnosis. Relevant information from the other sections of obstetrics history should be included in HPP based on the woman's complaint. Past obstetrics history, it includes the detailed chronological documentation of all previous pregnancy. Since most of the major obstetric complications are recurrent, it is very important to take this one in detail. So it includes the year of occurrence, length of gestation, duration of labor, fetal birth weight. If remember, the fetal outcome, male, female, fetal presentation, mode of delivery, presence of antepartum, intrapartum, and postpartum complications should be mentioned. Under past gynecologic history, the contraceptive history, if it was not mentioned in HPP, menstrual history, sexual history, history of female genital mutilation, and the previous history of gynecologic surgery or procedure should be mentioned here. Under past medical and surgical history, like the details of the chronic medical illness should be mentioned, since the pregnancy may worsen the chronic medical disorders, and these medical disorders can also have a negative impact on the pregnancy outcome. We need to elicit this one. History of blood transfusion, history of drug sensitivity, these are very important. Under personal history, personal and family history can be combined together. So history of smoking, alcohol intake, habitual drug use are very important. Under family history, her sibling, parent, children, whether the parents are alive or dead. If dead, the reason for death should be mentioned. Family history of chronic illness, hypertension, diabetes, family history of twinning, birth defect, hereditary illness should also be described under this heading. The final is the review of system or functional inquiry. What was missed on the other parts of history should be elicited under the review of system. Thank you for watching. If you are new for this channel, don't forget to subscribe the channel to have more videos.